All right, guys, I'm going to just go over what we didn't get to cover in class. Now, this is not the blueprint. I'm going over a lot more extensively, but be sure and look at your blueprint when it comes out and focus on what I put on your blueprint. So let's start on page 384, where we stopped off at. General systems assessment, heart, lung, skin. Just know that we have to assess laboring moms just like we do any patient. You have to do a complete head-to-toe assessment. Vital signs, same thing. We're going to reassess anything that's elevated after 30 minutes. We obviously want mom to lie on her side as much as possible to prevent supine hypotension. Leopold's maneuver. This is done using abdominal palpation. You find the fetal parts in the fundus. Where's the back? Where's the presenting part? Is the head down? Box 16.5 has the process for you. This is where you will review this to go to your simulation lab where you're going to do this. Assessment of fetal heart rate and pattern. The point of maximum intensity of the fetal heart rate is on mom's abdomen where we hear the fetal heart rate the loudest. It's usually right over the back. If the baby's vertex is going to be below the umbilicus. If their breech is going to be above. Table 16-2 or point 2 shows how often to assess. Depending on the stage of labor, it's between 15 and 30 minutes. I guess probably the most important thing on this slide is that we assess the fetal heart rate after rupture of membranes, no matter how they're ruptured, because it's the most common time for that cord to prolapse or to follow the fluid out, and then sometimes the baby's head will cork in there and cause a medical emergency. All right, assessment of uterine contractions. We know that effective labor brings forth regular contractions. The more frequent, the more intense, the longer they last. These things we expect, but they don't always directly relate to progress. These are primary powers, and we've discussed these before. What I need you to know is when we do assess contractions during labor and delivery, we have to assess frequency, from the beginning of one to the beginning of the next. Intensity, which is the strength. If it's an external monitor, all I can tell you is that it's mild, moderate, or strong. The duration is how long it lasts from beginning to end. The resting tone, the tension of the uterus between contractions, we call it the relaxation time. Figure 16.6 shows how the abdomen changes in appearance during contractions. And we can measure these externally or internally. We usually assess these every 30 minutes. Depends on your stage of labor. If you have Pitocin going, it's going to be every 15 minutes assessment of uterine contractions. One of your safety alerts says that any abnormal contraction has to be promptly reported. They use graphs and plots. The care provider decides when there's failure to progress. One safety alert says that an abnormally prolonged labor is not considered cause for concern unless the fetal maternal unit exhibits stress. Mom has fever, the fetal heart rate's abnormal, like with ruptured membranes that's been prolonged. As far as the vaginal exam, this is how we know if contractions are reflecting true labor, only performed when indicated on admission to get a baseline and when something significant happens. We do not check them routinely every hour, every 2 hours. Every time mom says, would you check me? I think unless she has had her fluids rupture, there's just a change in the way the baby is acting. There's got to be something apparent for us to do this. Lab and diagnostics. We pretty much know that every time a pregnant woman goes to the doctor or the hospital, we get a urinalysis. It can tell us hydration, nutrition, infection. If there's more than 1+ protein, we're going to worry about preeclampsia. We're going to start blood. Usually we do that when we start the IV, we go ahead and get the blood. We want a CBC, hematocrit. We want platelets. We need to know if there's any kind of coagulopathy, because this would contraindicate an epidural if the platelets were off. Rapid HIV if that's undocumented, type and screen, determine blood type if it's not already done. Other, group B strep, we know that we do that. We may have to give them antibiotics. All right, assessment of the amniotic fluid and membranes. 25% of women will have spontaneous rupture of membranes, and it initiates labor. Usually you don't see more than a 24-hour lag for labor to start. The most common time, though, for rupture is during the active phase of the first stage, and remember that is 6 to 10 centimeters. There's AROM, artificial rupture of membranes. An amniotomy is performed. It looks like a crochet hook, has a little sharp end on it. When the fetal scalp electrode is inserted, if the membranes haven't ruptured, it's sharp, it will pop it as well. This does increase pressure and pain. Sometimes it will progress labor a little bit. We have to record the time regardless of the method of rupture. And we also document TACO, time, amount, color, odor. Safety alert. Anytime membranes rupture, there's a chance for prolapsed umbilical cord. That is an emergency. We have to monitor the fetal heart rate closely. What you'll see if a cord prolapses is you're going to see a very prolonged deceleration. The baby's heart rate is going to go down. It's just there's no circulation. It's an emergency. Once membranes are ruptured, we have to worry about infection because bacteria can ride right up into the uterus now. Chorioamnionitis, placentitis. We want to limit vaginal exams, watch the temperature, and discharge. And this is done at least every 2 hours. Box 16.7 on page 390 has signs of potential complications. They're listed here for you. I'm not going to read them to you, but you probably need to know those. Nursing interventions. Next slide. Take a look at these nursing interventions on your own, table 16.3. Pretty much common sense stuff here. We want to encourage these ladies to void every 2 hours. A distended bladder can prevent the fetus from engaging and descending. Epidurals can increase our risk for urinary retention, so we will have to assist them to the bathroom. In early labor, give bedpans later. We may have to catheterize. Usually a straight cath right before they're ready to push. There's times that sometimes that presenting part is keeping you from being able to even put that catheter in. It can occlude the catheter. Bowel elimination. Most women do not have a bowel movement while in labor due to decreased intestinal motility, but if there's a large amount of stool, that can prevent them from getting the baby into the canal. A nursing alert. If the woman states that she has an urge to defecate, we have to check them. We have to do a vaginal exam because she may be ready to deliver. Take her by her word, trust me. No more routine enemas. There's no evidence to support that procedure. I guess you noticed I skipped a couple of things. Just remember what the doula that talked to us at the seminar talked about. Her responsibilities are not nursing in any way. Second stage of labor. The baby is born. Begins with 10 centimeters and ends with the birth of the baby. Uterine contractions, gravity, maternal bearing down, all that helps with a spontaneous birth in most cases. The length of the stage depends on parity, anesthesia, woman's age, BMI, etc. Typically, multip 2 to 3 hours, nullip 3 to 4 hours. There's 2 phases, just like the second stage of labor, just like in the first stage, the latent and active. With the latent, there's a passive descent. When this happens, pushing usually starts within 1 to 2 hours if there's no fetal descent or if there's no urge to push. Active, there's a strong urge to push. Ferguson's reflex is activated as that presenting part presses on that pelvic floor. Oxytocin is released and contractions get stronger. We usually get them to push when they can feel this pressure. And again, open glottis pushing, see table 16.4 for expected progress in the second stage. During the second stage, if they're not completely dilated and effaced yet, we don't have them push. Sometimes we have to have them breathe through contractions. If they do start to push before that cervix is out of the way, it can actually prevent vaginal childbirth, and it can cause injury because of swelling. So they have to be completely dilated and effaced. Assessment is going to be up to your facility, how often during labor and delivery, but 16.2 box has some assisting with emergency birth. As far as maternal position, there's no ideal position. More comfort. We avoid the lithotomy, which is probably the doctor's favorite position. Squatting can help increase the diameter, but can also cause perineal lacerations. Better for pushing, but not so much for delivery. For delivery, we kind of need a little more control over that baby head. That's what causes the perineal lacerations when it pops out too quickly. Again, they're talking about the urge to push down as that fetal presenting part reaches the pelvic floor. It is involuntary, and it's called the Ferguson reflex. While pushing, if mom's making kind of noises, then that's considered an open glottis push, and that's what's recommended. And this is why closed glottis pushing activates the Valsalva maneuver. We know that reduces cardiac output and perfusion to the placenta and the baby. So open glottis pushing, 6 to 8 seconds, 2 to 3 times during a contraction, only when there's an urge to bear down. As the fetus crowns, she may push spontaneously, and they also may decide they don't want to do this anymore. This is when things start hurting sometimes, and they kind of feel like they're maybe worried that they're going to tear. So we may have to help them to breathe and to just assist them with this part of pushing. Immediate assessment and care of the newborn. Time of birth, when the whole body is out, we look at the clock. We give skin to skin if allowed, put a hat, get them dry first. Get them dry, get the wet stuff away from them. We can wait up to 5 minutes to clamp the cord. If it's allowed, at least 2 nurses should be present for each birth according to A1, one for mom and one for baby. APGARs are 1 in 5 minutes. We can even do this while skin to skin. We postpone that big assessment and the ID and everything until later. Perineal trauma can relate to urinary or fecal incontinence later in life. We want to help reduce this trauma. Apply warm compresses, sideline position to birth the baby. Some degree of trauma occurs with each delivery. Sometimes it's very minute. Nullips have more pronounced injury due to firmer, more resistance to stretching in their tissue. Nutritional status, the birth position, the pelvic anatomy, fetal position, size of the infant, the use of forceps or vacuum can all cause perineal trauma. Kegel exercises prenatally and postpartum improve and restore that tone and strength. Perineal lacerations occur as the fetal head is born, and we define them by depth. First degree lac extends through the skin and superficial structures. Second degree, through the muscles of the perineal body. Third degree, through the anal sphincter muscle, and the fourth degree completely through the anal sphincter and rectal mucosa. This may result in profuse bleeding. Some perineal injuries will heal without permanent disability regardless of repair. Vaginal and urethral lacerations can occur in conjunction with perineal lacerations. They tend to extend up the lateral wall, can involve the levator ani muscle, maybe because we've used forceps or the head descent has been very rapid or it was a precipitous birth. Cervical injuries occur when the cervix retracts over the head. Most very shallow injuries have minimal bleeding. Some extend into the vaginal vault and into the lower uterine segment. Serious bleeding can occur with these. I did have a lady that had a previous cesarean section. She went really, really quickly. The doctor decided to let her VBAC, vaginal birth after cesarean. I think he got a little nervous as she was pushing, and he decided to help out with some forceps. Well, when we got her back from the C-section room, she continued to bleed. We would massage your fundus, and it wouldn't take very long and it would fill back up with blood. You know, the uterus can actually hold up to 500 mils of blood. So we would, you know, vigorously massage that fundus and it would just keep on. Finally, he took her back to surgery and there was a laceration of the cervix. He had to suture that up. She was not going to stop bleeding. An episiotomy, it's an incision made to enlarge the vaginal outlet. It's declining and being performed now only about 10% of the time in the U.S. Some older docs kind of feel like everybody needs one. The problem with episiotomies sometimes is once we've made a small cut, even if it's very shallow and very small, it allows more tearing. We've already disrupted the integrity of that tissue. It's like if you've ever had a sheet and you can't really tear it, but if you snip the tiniest amount of that sheet, it tears very easily. It's that kind of a concept. Midline episiotomies are the most common. They're easily repaired, least painful. Medial lateral are more difficult to repair and also can tear to a higher degree. We should never do these routinely. Third stage of labor. Birth of the baby until the placenta is expelled. It's usually the shortest stage of labor. Care management. What we want is prompt separation, expulsion of that placenta in the safest, easiest manner. It's attached to the decidual layer. There's like a postage stamp to a sheet that you purchase. These strong contractions and sudden decrease in uterine size cause that placental site to shrink. The anchor villi break and the placenta separates. Now they recommend an active management of this third stage of labor. Oxytocin medication right after the baby but before the placenta. That's not like it used to be. We waited until the placenta was delivered and then put Pitocin in. At this point, the practitioner gently has this continuous traction on the cord until it separates and is expelled. Immediately, we do fundal massage. There's less risk for postpartum hemorrhage with this and decreased anemia for both mom and baby. We have to examine that placenta, regardless of how it comes out, for intactness to make sure that we didn't leave any fragments behind in the uterus, because that uterus will not get back to normal size and you will have continuous bleeding if we have any remaining fragments. Blood samples from the umbilical cord for type and Rh status is done. Some people will collect some of this blood for future storage of stem cells for their other children. Care provider will examine mom for lacerations and repair those as needed. The baby nurse will administer the routine baby meds at this time or let mom do skin to skin. The fourth stage of labor. This begins with the expulsion of the placenta and it lasts until the woman is stable in the immediate postpartum period, and that's usually within the first hour or 2 hours. Care management, many will stay in the same room until they're completely stable. Others were transferred to a postpartum floor. It just depends on your facility. Babies usually remain in the mom's room now if they don't have to stay in the nursery for some reason. Assessment, we need a good report. Anything that predisposes this mom to hemorrhage, we need to let them know. Did we do oxytocin? Did she have this Pitocin on for 2 days? Was it a precipitous labor? Is she a grand multip? Has she had 5 or more babies? Did we induce labor? Table 16.5 has some assessments during the fourth stage. We're going to do the blood pressure every 15 minutes for 2 hours. Pulse, temp, the position of the fundus. We measure that as finger breadths below or above the umbilicus. If I am one finger breadth below the umbilicus, I'm going to document it like that. If I'm at the umbilicus, I'm just going to put it like this. We're going to massage it if it's not firm. We're going to watch for the bladder, because if full bladder happens and the bladder's kind of, the fundus is kind of shifted to the right and their uterus is boggy, then they're going to start bleeding. So we're going to check to make sure that their bladder's emptied. We're going to massage that fundus. We're going to assess the color amount, whether there's clots, odor, and the episiotomy at this time. Post-anesthesia recovery. As with anyone having surgery, they should not have numbness or tingling in their extremities. They have to be able to move their extremities and have normal vital signs and no TSATs. We should not ever discharge a woman from recovery until she's completely recovered from these effects of anesthesia. Care of the new mom, regular diet as soon as they want, usually clear liquids right away until their stomach kind of settles down. Care of the family, look over this, look at the family newborn relationships, check those out. All right, this is chapter 17, labor and birth complications. We're going to talk about preterm labor and birth, premature rupture membranes, dystocia, obesity, post-term pregnancy, obstetric emergencies, and this is our last chapter for our module 2. All right, here's some terms that you just need to remember. Preterm labor is when we have regular contractions that cause cervical changes of at least 2 centimeters. And preterm birth is any birth between 20 weeks and 36 and 6/7 weeks of gestation. We categorize them as very preterm, moderately preterm, and late preterm. You don't have to remember those. 75% of the babies in the U.S. are late preterm, between 34 and 36 and 6/7 weeks. We know that before 32 weeks is the riskiest time, and you know why, because we've talked about it and everybody's talked about it. Surfactant is just not sufficient yet. You're going to need to know that, not just for my test, for HESI, for state boards. Just remember those 32 weeks. So preterm birth is not the same as low birth weight, okay? Not the same. Preterm less than 37 weeks, regardless of how big this baby is. Can I have a 9-pound preterm baby? Sure. These little gestational diabetes or these DM moms can have big babies that are absolutely not mature. Low birth weight. Weight at the time of birth is 2,500 grams or less. That's less than 5.5 pounds. This may be attributed to IUGR, but most of the body systems are fully developed. All right, spontaneous versus indicated preterm birth. There are 2 categories. Spontaneous occurs with early initiation of labor in the absence of maternal or fetal illness. 75% of all preterm births are this type. Box 17.1 on page 419 has the risk factors for spontaneous preterm labor. If there's genital tract colonization infection, African American race, any kind of bleeding of uncertain origin, maternal cigarette smoking, substance abuse, those are just to name a few. An indicated preterm birth is iatrogenic. This means that it occurs to resolve a maternal or fetal risk related to continuing the pregnancy. 25% are these type. 17.2 has your common causes of indicated preterm birth. We're only going to discuss the spontaneous premature labor and birth in this chapter. Again, look at 17.1 box, risk factors for spontaneous preterm labor. It can be multifactorial. We already talked about a couple of these. Periodontal disease. The only thing interesting about this is they say periodontal disease can cause preterm labor, but when they actually studied it, going and having dental work done has not helped with this. So it's not really documented. My theory is maybe it's the activities that lead to the periodontal disease that affects the preterm baby. I don't know. That's just theory according to Betha. All right, structural abnormalities of the uterus, placental implantation. The thing is that as number of bleeding episodes increase, the risk for preterm delivery increases as well. We also have to think about uterine overdistension and what could cause this. Too much amniotic fluid is called what? Polyhydramnios, but also multiple gestations. We have 2 or 3 babies in there. That uterus can only get so big before it says, that's it. I can't do this anymore. All right, predicting spontaneous preterm labor and birth. So we've already talked about risk factors. We know that we can prevent some we can't. We can definitely stop smoking, but we can't help our culture or our our skin color. Those things are our ethnicity. Those we can't help those. So cervical length is interesting. It's a predictor of preterm labor. When they measure this by sonogram, if it's greater than 30 millimeters in the second and third trimester, it's unlikely that they're going to go into labor, even if they have symptoms. And then there's the fetal fibronectin test. This is a glycoprotein glue that's found in the plasma and produced during fetal life. It appears in the cervical and vaginal secretions early in pregnancy and again in late pregnancy. We collect it. It's known to be a cause of spontaneous PT labor, and we use this in conjunction with that cervical length. It can identify people that are at risk for up to 7 days in that window, and also those that are low risk. All right, take a look on page 424, box 17.3. All women must be taught signs and symptoms of preterm labor, because all women are at risk, and if you've had preterm labor before, you're more at risk, but every pregnancy is different. So take a look at these. They're right here for you. All right, lifestyle modifications. Sometimes for preterm labor, they will put you on bed rest, tell you to hydrate, and limit work. There is no evidence that this is effective. What does it increase our risk for, though? Thrombus, muscle atrophy, cardiovascular deconditioning, endocrine changes, glucose intolerance, all this stuff. Not to mention the stress, strain, and psychological concerns of not being able to work and take care of your family. So, something to think about. Pelvic rest, a lot of times doctors will tell someone that is at risk for preterm labor or not to have sex, because it can actually throw them into labor as well. Home care, modify the environment, put that Yeti by the bedside with the sodas in it, the water, hopefully water's better, a remote control cell phone and chargers. All right, so we've talked about preterm labor. So let's talk about suppression of uterine activity, specifically tocolytics. This is a medication given to arrest labor after contractions and cervical changes have occurred. No meds have been approved for tocolytics by Food and Drug Administration in the U.S. So why are we talking about this stuff? Because we use it in an off-label manner. Some of you have seen them use Cytotec in labor and delivery to induce labor. This drug is the same thing. It's not been approved by the FDA to use in this way, but we use it this way. For Cytotec, it's an abortifacient. As prescribed, it's approved for ulcers. That's why we tell people not to share medications. A pregnant woman that took this Cytotec, it could actually cause an abortion. We want to use our gloves when we handle it, that kind of thing. But that's not what we're talking about. We're talking about suppression of activity. So let's get talking. First, let's talk about contraindications to using a tocolytic. Page 425, box 17.4. For maternal contraindications, there's preeclampsia or gestational hypertension with severe features, hemorrhage, or significant cardiac disease. For fetal contraindications, it is gestational age of 37 weeks or more. We just let those go. We're not going to put everybody through this if they're 37 weeks. If there's fetal demise, if there's some type of lethal fetal anomaly, such as anencephaly or something like that, if there's chorioamnionitis, or if there's evidence of acute or chronic fetal compromise. Box 17.5, look that over. Nursing care for the woman receiving tocolytics. And let's specifically look at mag sulfate. We need to know the signs of toxicity. We need to use prepackaged infusions for this. I know that doesn't always happen in smaller places. And we have to worry about neonatal hypermagnesemia. It's rare, but there's respiratory depression. They're a floppy baby. They need resuscitation. So magnesium sulfate is the most commonly used tocolytic agent because maternal, fetal, and neonatal adverse reactions are less severe than with some of the beta adrenergic agonists. It's not really supported by the literature, but you're still going to see it used. Here's the thing. Look at your safety alert on page 425. We have to assess the respiratory status, deep tendon reflexes, and level of consciousness because we need to know if there's toxicity. You guys have looked at this. You've done med cards on it. You just have to remember the mag sulfate. Also with terbutaline, it's also an asthma med. Breathine is the brand name. It's a beta adrenergic agonist. It relaxes the uterine smooth muscle. It stimulates the beta receptors. We give it sub-Q to assist. Say we need to transfer them. We just need to slow them down a little bit. Maybe we need to give them something to mature those lungs. It's 0.25 milligrams every 4 hours, not to be administered for over 24 hours. What do you think the most common side effect of this terbutaline is? It's increased heart rate, anxiety, feeling of nervousness. So if someone has cardiac issues, we can't give this. It can cause cardiac arrest. Calcium channel blockers. In labor and delivery, procardia, adulate, they can suppress the contractions because, here's your path though, it prevents calcium from entering that smooth muscle. It reduces contractions. It's fairly safe. It's cheap. I've known about this medication has been around forever. 10 to 20 milligrams POQ 3 to 6 hours. It can cause hypotension because that's what we give it for, right? A headache, dizziness. We won't have them get up slowly because of orthostatic hypotension. We do not give this with mag sulfate. It can cause a complete muscle blockage. Also, we don't give with breathine because of the blood pressure and pulse. Indomethacin, we're not going to talk about it because we're not going to use it. It's not good. So check out tables 426 through 428 with these meds on them. It's really good. When you're doing your blueprint, it'll has it all in one place. All right, so we want to promote fetal lung maturity. We're going to use antenatal glucocorticoids. Betamethasone, dexamethasone, these are given IM to mom. It accelerates fetal lung maturity by stimulating fetal surfactant production. It's the most cost-effective and efficient method to prevent morbidity and mortality in preterm births. 24 to 34 weeks is when we give it if there's a preterm birth that's threatened. Also, it can be between 34 and 36 weeks for someone at risk who's not yet received steroids. We can repeat this dose in 2 weeks. All right, medication alert, page 428. Between 24 and 34 weeks of gestation, anyone at risk for preterm birth should get a single dose of antenatal glucocorticoids. But because we need 48 hours from the time of that injection, in order for the fetus to receive optimal benefits, we have to do it promptly. We have to figure it out very quickly and get it administered. There's a med guide, page 429. It is, again, off-label use. There's your action. Stimulates lung maturity by promoting the release of enzymes that induce production of surfactant. But it also works on the brain, kidneys, and the gut to help them mature as well. The indications: prevent neonatal respiratory distress by accelerating lung maturity. Doses and routes. Take a look at those. Maternal effects. What is the main thing that we want to look at? Anybody getting steroids. Hyperglycemia. Yes. Fetal effects. Decrease in fetal breathing movements and body movements. That's usually transient. Nursing considerations. This stuff hurts. Deep IM. Ventrogluteal or vastus lateralis. Not oral. Only IM. Does not affect maternal blood pressure, but we do need to assess blood glucose. Mom that's been really controlling her diabetes may not be in such good control right now for a while. All right, to manage inevitable preterm birth. When it's expected to occur within the next 24 hours, we want mag sulfate for at least 24 but less than 32-week gestation, but not longer than 24 hours. A loading dose of 4 grams over 30 minutes, then a maintenance dose of 1 gram per hour. At 4 centimeters, birth can occur. The cervix does not have to completely dilate for these little guys to pass through. Fetal and early neonatal loss, congenital anomalies, or genetic disorders that are incompatible with life are the most common cause. A lot of times parents are going to be aware of this as an outcome. They definitely need a plan that is acceptable to everybody. Early on, you need to find out, do they want to see and hold the baby? Just keep in mind they may change their minds several times. Some moms may want to be taken to another floor afterward. Premature rupture of membranes. This happens spontaneously before the onset of labor. Preterm premature rupture is before 37 weeks, and that usually occurs about 10% of the time. Some causes would be infection, inflammation, stress. Box 17.6 has some risk factors for this. It can be a slow leak or a big gush. Chorioamnionitis is the most common maternal complication from preterm premature rupture of membranes. Major complications of pregnancy. Fetal complications are related to infection, cord prolapse, cord compression due to oligohydramnios, not enough fluid. Care is going to depend on the gestational age, the risk factors, the neonatal complications. If 37 weeks or later, we can birth that baby. Those babies will be fine. 32 weekers who need to cook longer, maybe there's risk for umbilical cord compression. At 32 weeks, if we have pulmonary maturity documented, we could go ahead and deliver. It's just going to depend on what's going on with this particular pregnancy. If we manage instead of deliver, we're going to do daily fetal assessments. We talked about these last module, non-stress test, BPP, kick counts. We're going to watch for signs of labor, infection, anything over 100.4, on and on. Chorioamnionitis, a bacterial infection of the amniotic cavity. It happens in about 25% of preterm births. Amnionitis, intrapartum infection, or other terms you may hear. We're going to diagnose this based on clinical findings. Maternal fever, over 100.4, maternal or fetal tachycardia. Baby tachy is over 160. The uterus is going to be tender. There's going to be purulent amniotic fluid. Usually amniotic fluid is very clear. It's not real sticky. It's not thick. And this is going to be an absence of other infections. This is caused by normal flora because our membranes have been ruptured too long, maybe too many vaginal exams, maybe that internal monitor that we stuck in there. Younger women and first-time moms, it's more at risk. Maternal risk, bacteremia, dysfunctional labor, may end up with a C-section, pelvic abscess. Neonatal risk, pneumonia, bacteremia, meningitis, respiratory distress, and death, cerebral palsy. We're going to treat very promptly with broad spectrum antibiotics, and that baby needs to come out. Ampicillin, afterwards we're going to have clindamycin or flagyl. And actually by treating group B strep, now we've kind of reduced the incidence of this. All right, let's talk about post-term pregnancy, labor, and birth. Okay, we can call it post-term, post-mature, or prolonged pregnancy. Anything over 42 weeks. This is less than 0.05% of the time. Here are some things you may see. Maternal weight loss of 3 pounds per week. A decrease in uterine size, meconium in the fluid because it's time for that to happen. Advanced bony maturation of the fetal skull. Maternal and fetal risks. There's risk factors for post-term delivery. With the mom, labor dystocia, severe perineal injuries, chorioamnionitis, endometritis, postpartum hemorrhage, C-section birth, and all the risks that are associated with that. Maybe induction forceps vacuum extractions. For fetal, there's abnormal fetal growth. They can be SGA, but they can also be macrosomic. The placenta continues to feed them. It just depends on what's going on. There's risk for decreased amniotic fluid, again called oligohydramnios. Potential for a prolapsed cord or a cord compression. The meconium and the increased risk for aspiration. You'll see a baby with no sub-Q fat, dry, cracked, peeling skin, long nails, and meconium-stained fingernails, skin, and cord. They've just cooked too long. All right, care management for postpartum. There is big risk for stillbirth. We have fetal assessments, non-stress tests, contraction stress tests, BPP, once or twice weekly. We're going to induce that labor by 41 weeks, but they're going to have to do those daily kick counts and assess for signs and symptoms of labor. We have to monitor these guys very, very closely during labor. They may need amnio infusion for oligohydramnios. It's going to help put some fluid back in there and keep that cord from getting compressed so much. All right, dysfunctional labor, also called dystocia. Dystocia is lack of progress in labor for any reason. Dysfunctional labor is a long, difficult, or abnormal labor. These are responsible for up to 60% of our C-sections. Maternal causes ineffective contractions. Maybe it's maternal pushing, altered pelvic structure, or bony or soft tissue abnormalities. Fetal causes presentation, position, or development. Latent phase disorders. Hypertonic uterine dysfunction. There's painful, frequent contractions, but they don't change the cervix. This usually occurs before 6 centimeters. The contractions are in the midsection of the uterus, not the fundus. Remember the balloon and the ping pong ball. Downward pressure is not being put on that presenting part, so it's not doing anything but uncomfortable. It's just wearing them out. This can last for days. They're exhausted, they're in pain, they need rest, they need sleep. Sometimes we have to let them sleep, give them some Ambien, start over again tomorrow. All right, active phase disorders. So there's protraction disorders, slower progress than normal, or arrest disorders, where there's no progress in labor. Most commonly, it's just inadequate uterine activity, a hypotonic uterine dysfunction. Normally, they'll progress initially, then the contractions become weak and stop. With these cases, the intrauterine pressure is usually less than 25 millimeters when they've got an internal monitor, and there's just no effacement or dilation. Common cause is CPD. What is that? Cephalopelvic disproportion. There'll be fetal malposition. Maybe the head is extended instead of flexed. The occiput posterior presentation, remember the LOP, ROP. Maybe there's a brow or face presentation. That smallest diameter of the head is not coming through and it's just not working. To determine arrest in the first stage, we have to assess uterine activity with an IUPC. If the fetal presentation, position, station, or weight are evaluated to be normal, we may augment the labor. We're going to start some pit and rupture their membranes. Secondary powers. Bearing down efforts can be influenced by analgesia, anesthesia. Maybe they can't feel to push, they're exhausted, there's not enough food and liquids on board, and positioning that we put them in can work against us. 17.1 characteristics of dysfunctional labor. Take a look at these. Look at your risks. Active labor, remember, begins at 6. 2 hours can pass during active labor without cervical changes. That's normal. Precipitous labor. Labor lasting less than 3 hours from the time of onset of contractions to time of birth. The causes can be hypertonic uterine contractions that occur when you have a placental abruption, uterine tachysystole, even recent cocaine use can cause this. Maternal complications, that uterus can rupture. There can be lacerations of the birth canal. There can be an amniotic fluid embolism and postpartum hemorrhage. Fetal complications, hypoxia. The uterus is not relaxing with these tachysystolic uterine contractions, and we know that when the uterus is contracting, there is not much blood flow to that, or there's reduced blood flow to that baby. It can also be intracranial trauma from rapid birth for this baby. The thing to remember is the woman knows her body, and if she says she needs to push, you better believe her. Alterations in pelvic structure. There can be a pelvic dystocia. There's pelvic contractures that reduce the capacity of that bony pelvis to accommodate that baby. Maybe it's congenital, maybe it's a neoplasm, trauma. We've fallen and broken our tailbone. And then, of course, adolescence because they're not mature yet. Soft tissue dystocia, obstruction of that passageway. An example that we gave early on was STDs, right? Condyloma, can actually be in those clusters, and it can prevent that baby from coming through that birth canal. Full bladder, we talked about that. Stool, cervical edema, we talked about pushing before we're complete. All right, we're skipping to induction of labor. Chemical or mechanical initiation of contractions before they spontaneously occur. Elective or medically necessary. In 24% of births between 37 and 41 weeks, we induce them. Look at page 439 for indications and contraindications. Read over especially the contraindications. Relative does not always mean contraindicated. So let's take a look. You need to know what just the plain contraindications are. The relative contraindications, don't pay any attention to those. So if there's acute severe fetal distress, we are not going to induce that baby. If there's a shoulder presentation, the baby's in a transverse lie, nope, because it's not coming out that way. If the baby is up floating and it's not engaged, you're just going to prolapse a cord. If there's uncontrolled hemorrhage, a placenta previa, where the placenta is sitting over the cervical os, you open up that os and you're just going to have hemorrhaging. And if there's a previous uterine incision that prohibits a trial of labor, those are going to be contraindications. Elective induction. There's not a medical reason. We're going to ripen the cervix. A balloon cath can enhance the success of this. We don't want to do this before 39 weeks have been completed. The most common method are oxytocin and an amniotomy. Cervical ripeness Bishop score, a score of 8 or more, says that cervix is conducive to induction. Cervical ripening methods. There's chemical agents. You're going to hear of prostaglandins. They ripen, which means they soften and thin the cervix and help it inducible, right? So cytotec, prostaglandin E, dinoprostin. You're going to hear Cervidil, Prepidil. Spontaneous labor can actually start after we administer this. And again, these are not approved by the FDA. We use them as an off-label use. Look at page 440, 441, this med guide, read over those. What I don't like about a tablet or a gel is I can't remove it if the uterus gets too, has tachysystole, you know, it gets too tacky and it's too often and the contractions get too intense. I can't just remove that. With dinoprostin, I have it's a little impregnated gauze with a string on it. I can take that out. With Cytotec, we use a tablet. They come in 100 or 200 microgram doses. We have to cut the pill up to 25 microgram dose and repeat every 4 hours. Mechanical and physical methods. Mechanical dilators will stimulate the release of prostaglandins. We actually can use a Foley cath inserted into the cervix to help do this. There's also hydroscopic dilators, and we can strip the membranes as well. Alternate methods, castor oil. Do not do the castor oil. You will just be sick and going to the bathroom, and it does not work. Yuck. Amniotomy. Artificial rupture membranes, AROM. It can induce labor. Usually it'll begin within 12 hours. It can decrease labor up to 2 hours, but we've set a clock once we've done that. Prolonged rupture, infection, cord compression, or prolapse. The amni hook, we talked about the little crochet looking hook that they use with the tiniest little sharp end to it. Again, presenting part has to be engaged, free infection, and fetal heart rate immediately after amniotomy. We're going to check temperature every 2 hours. We've talked about this. Legal tip, it's outside the scope of most nurses to perform an amniotomy. It requires special training and facility protocols. All right, Oxytocin, probably the most favored way to induce labor. What is it? It's a hormone. It's produced by the posterior pituitary gland, and it stimulates uterine contractions and aids in milk ejection. It's the synthetic form that we use to induce or augment labor, but it's also the most common drug associated with adverse events. Usually it's related to our dose. We do Rambo pit, right? We double it every 20 minutes as often as we can, just as quickly as we can. We're not supposed to, but sometimes we do that. Safety alert. It's a high alert med. There's high risk for harm when used in error. The maternal risks: placental abruption, uterine rupture, an unnecessary C-section, postpartum hemorrhage, and infection. Because we increase this Pitocin, the body kind of gets a little bit resistant to the oxytocin. So after delivery, these guys are going to require probably a little more attention because their funduses are going to be a little boggy. There's fetal risks: hypoxemia, acidemia, that results in late decels and minimal or absent variability. Here's our most common regimen. It has a very short half-life. That's why we double it like we do. It usually takes about 40 minutes to get that steady rate. Higher dose protocols are known to shorten labors and have fewer failed inductions, but have a whole lot more uterine tachysystole and more C-sections. All right, nursing considerations. There has to be a standard. There has to be a standard concentration, a standard preparation, a standard procedure, and there also has to be a standard definition of uterine tachysystole. And this has to be not including the fetal heart rate or the woman's perception of pain to define this uterine tachysystole. So the common definition for uterine tachysystole is more than 5 contractions in 10 minutes, averaged over a 30-minute period. Look at the emergency treatment box on page 445, and you need to be aware of this. And really, when you do interventions for the pregnant mom, it's always going to be change their position, put them on their left side, give them some oxygen. Those are always going to be options. And then depending on the severity of the fetal heart rate or whatever, then we may start giving an IV bolus. We may or may not stop the Pitocin and those kind of things. All right, an operative vaginal birth just means that we're going to use forceps or vacuum to assist in a vaginal birth. The two curved blades look like salad tongs, page 17.3, page 445, table 17.3. The ones I really want you to know are the outlet, where the fetal scalp is visible on the perineum without touching it, and the low, where there's fetal head at least a +2 station. The mid-pelvis, the fetal head is engaged no higher than 0, but above a +2. The indications, maybe we need to shorten this duration of the second stage. Most of the time it's for fetal reasons and non-reassuring fetal heart rate. In order to do this, there are conditions that have to be followed. There has to be a completely dilated cervix, and the bladder has to be empty, the preceding part has to be encaged, and the membranes have to be ruptured. The doctor does this. He places these salad tongs, one on each side, and then they lock together. Mom may or may not push. If the fetal heart rate is decreased, they remove them and reapply them. The safety alert says the fetal heart rate has to be recorded before and after forceps attempts because we know the cord can become compressed. Nursing interventions. The nurse will obtain the correct forceps. Explain to the patient that they fit like tablespoons holding an egg. Assess for vaginal or cervical tears, uterine retention, bruising on the baby, scratches, facial palsy. The vacuum-assisted birth, called a vacuum extraction, we put this little plastic cup on the fetal head, and it uses negative pressure to assist in the delivery. It's not used before 34 weeks because this baby's vessels are too delicate. A prerequisite is complete dilation, ruptured membranes, and engaged head, no CPD. The vacuum cup will be applied by the doctor. There's two different kinds. One, the doctor can control the suction himself. The other one, the nurse has to control that suction. So what happens is the doctor will put the cup on the baby's head. The nurse will suction it just enough for it to hold on, just a couple of little cranks, and it holds on real well. Once there's a contraction or he wants to pull, then you will increase that suction to about 450. There's usually a meter that has green and red, and we want to stay in the green section as well. You're going to see a baby with more molding with this and going to have more of a cone head than usual. Obstetric emergencies, meconium stained fluid. The baby has passed his first stool. It's green, it's in the amniotic fluid, it's thin, or it can be thick like pea soup. 3 reasons: because it's time to poop, we're breech, or there's been hypoxia somehow. There's been cord compression or hypoxia in some way. The problem is that they can have meconium aspiration syndrome, aspiration pneumonia, especially if they're post-term. Safety alert. At least one person responsible for the baby who can do CPR and a complete resuscitation, including endotracheal suctioning at every birth. Care management is not recommended to suction the mouth and the nose and endotracheal suctioning as soon as the head is delivered. Now they want the whole baby delivered first. Look at page 454. Read over that emergency treatment. This is taking me for freaking ever. Shoulder dystocia. Andrea talked about this in detail on your seminar day. It is not common, but it is an emergency because the baby can get stuck and we have all kinds of problems. Look at your McRoberts maneuver on page 456. The Gaskin maneuver, you need to know those. All right, prolapsed umbilical cord. We've talked about this over and over. It is a medical emergency. The fetal cord lies below the fetal presenting part, and it compresses that cord. It can be visible or hidden. It's very common after rupture of membranes. It washes out with the water. A long cord, breech, or an unengaged fetus. Care management, prompt recognition. Hypoxia results in more than 5 minutes. We put a sterile glove on, we put our hand in there, and we push that presenting part off the cord. We put mom in knee chest position. We may need forceps or vacuum. They may have to have a C-section. What you will see: bradycardia, severe bradycardia, absent or minimal variability, a very prolonged deceleration or bradycardia, and there's an emergency treatment box on page 456. Another medical emergency, rupture of the uterus. Symptomatic disruption and separation of the layers of the uterus or previous scar. Fetus can be ejected into the peritoneal cavity. There can be uterine dehiscence, an incomplete rupture, separation of a prior scar. Signs and symptoms are going to vary. Decreased fetal heart rate, late or variable decels, absent variability, tachycardia, bradycardia. Maybe there's no fetal descent. Signs and symptoms of hypovolemic shock. Care management, we're going to prevent it. We're not going to labor someone with a classic uterine scar. We're going to watch for signs and symptoms of uterine tachycardia. Fetal mortality rate is 50 to 75%. Maternal mortality and morbidity can also be increased. All right, last slide. Amniotic fluid embolus, anaphylactoid syndrome of pregnancy. It's rare but devastating. Sudden acute hypoxia, hypotension, and cardiovascular collapse with coagulopathy. It's 1 in 8,000 to 1 in 30,000, so it's very rare, but it can occur during labor, birth, or 30 minutes after birth. The predispositions to AFE or rapid labor, meconium fluid, any kind of tear in the uterus or their pelvic veins, older moms, post-term gestations. If we induce or augment labor, they have eclampsia, we've done a C-section, forceps or vacuum, placental abruption or previa, and polyhydramnios. So just about anybody is predisposed to have this. Care management, emergency treatment box on page 458. You need to know the signs and the interventions. We're going to see very severe respiratory distress. We're going to see a circulatory collapse, hypotension, tachycardia, shock, hemorrhage. They're going to go into DIC. We want to oxygenate. Non-rebreather, 100% oxygen, may actually need to use the ambu bag. We're going to prepare for intubation and mechanical ventilation. We want to tilt to displace that uterus. We want to maintain cardiac output and replace fluid losses. Finish looking at that, and we are done with this lecture.